Hello and welcome to the Oral Apothecary Podcast, authentic chat about medicines, pharmacy and healthcare in the UK.
Pharmacist Jamie, Gimmo and STC take on topical and controversial stories but keep it edgy yet light-hearted.
Pod guests share their career-defining drug, song and book and also share their joyful patient stories.
Welcome to the Oral Apothecary Podcast. My name is Jamie Hayes. For this episode, we're joined by Anne-Marie Goacher. Anne-Marie is a pharmacist and lead for the Head and Neck Directorate at Brighton site of University Hospitals Sussex. We will welcome Anne-Marie in a moment as she shares a drug for our formulary, her career anthem, and recommends a book for the Oral Apothecary Library. Our micro discussion this week looks at the burden of acute eye conditions on different healthcare providers, published in the British Journal of General Practice last month, April 2024, for those of you on catch-up. First, let me welcome my two fellow apothecaries. STC is in Bournemouth and Gimmo is in Cardiff. Welcome both.
Evening.
Evening. Big news yesterday.
Yeah, are we in Perda? Are we allowed?
We are in Perda. Yeah, we're not allowed to say anything political, are we?
Yeah.
We're not allowed to say broken Britain or the plan's working or anything like that.
Well, I did see that July the 4th is a significant date.
Why is that?
Well, one of our alumni, Dr. Lucy Pollock, that's the day her second book drops, The
Yeah.
Golden Rule. Looking forward to it.
Yeah, I'm more interested in that, to be honest.
Absolutely.
So busy few weeks for me. I sadly didn't get elected onto the RPS, so thank you to anyone who voted for me.
Oh, commiserations.
But it was a shame. I did the Car 10, so big bike ride. You'll have to do it next year, Steve. So that's the Cardiff 10B bike ride. I just wanted to mention quickly. So you remember last episode we sort of talked about risk, and one of the things we mentioned was around the risk of doctors knowing best.
Or not.
Well, we were reflecting and editing whether we'd gone a bit far with that, hadn't we? But I think we left it in the end. But actually, this week, another piece of big news this week, on top of everything else, was the infected blood scandal. And so I don't know if you've seen that, but at the heart of that is the idea that some of the doctors involved did think they knew best.
Rory Stewart went to town on the Rest is Politics about that. He did not hold back, did he?
Yeah, and so again, you know, we know it's not everyone, but just another reminder for us that actually we were right to keep it in, and you know, it's a reminder for us not to get complacent.
It's all health professionals, or all professionals. You know, we all know bad apples, don't we? Whatever teachers, police officers, doctors, pharmacists, you name it. So yeah, we have to call it out when we see it, don't we? Got one thing to add to the risk story, actually, is, and I haven't recommended a podcast for a while, but you remember Professor James McCormack, who has been a guest on this podcast, who runs the Best Science podcast in Canada. And he has done 3 podcasts about statistics. And so if you were a health professional and you interested in what we talked about last episode, do check out, we'll put it in the show notes, do check out the 3 episodes that James and his colleague have done. They're really good, talking through and reminding you about inferential statistics. So yeah, big shout out for James McCormack.
Very good. I've been in London. You two missed the RPS Fellows Dinner, the RAF Club in Piccadilly. That was a great night. Several Oral Apothecary alumni in attendance, Claire, Delith and Diane. And then London again this week on coaching and leadership session with the Commonwealth Pharmacists Association. And so to meet a dozen of the team was inspiring. Travelled in from many parts of the globe. They are a class act, all of them. So I look forward to doing some work with them, actually, over the coming years.
Yeah, this is your solo apothecary effort to Singapore, isn't it, Jamie?
Nothing to do with the apothecary. Nothing to do with the apothecary. We all have other projects.
We don't mind, do we, Steve?
Not at all. Got my own. I wondered if it was anything to do with, again, when we had Diane Asheru on, because she was part of she ran, I think, didn't she, the UK Commonwealth Pharmacists Association?
I'm not sure, but she called in on the day, so I saw Diane last Thursday and again on Monday. Lovely to see her. She's also been very busy with the launch of the UK antimicrobial strategy recently. Let's move on. It's our great pleasure to welcome Anne-Marie Goacher. Anne-Marie is a frontline NHS hospital pharmacist, having worked across many specialties. The last 10 years have been within surgery, and she is now the lead for the Head and Neck Directorate at the Brighton site of the University Hospitals Sussex. She's the only ophthalmic and specialist uveitis pharmacist at her hospital, and what started as an arbitrary assignment of duties has now become her passion. Welcome to the podcast, Anne-Marie.
Hi, so pleasure to be here. Thanks for inviting me on.
We better start at the beginning, Anne-Marie, because people like that. So let's start. How did you, just tell the listener where we met.
So I met Jamie and Steve on the flight back from Bordeaux, attending the European Association of Hospital Pharmacy Congress. And you happened to be sitting right next to me. and we struck up a conversation, I believe, about our books, first of all. And about, I was reading, my own father had written a book, and I was reading that, and you had said your dad wrote a book recently as well. So we chatted about that for a while before we got into pharmacy topics. So yeah, it was a very, very nice flight back, full of nice chats. So thanks for that.
So we were a bit jaded because we'd been out. I think the term is clubbing.
Yeah. Yeah. Check with your children.
It was a Cuban bar. Yeah.
But yeah, you were sat next to me, Anne-Marie, and on your lap was Once There Was a Boy Who Survived by Maurice Heffernan. People who I sit next to on planes and trains, there's a conversation incoming most of the time, and a book is just an obvious one. And so when you said, yeah, it's my dad's book, I haven't quite bought it, Anne-Marie, but I have looked at it on Amazon and read the backstory.
Yeah.
And sounds an absolutely emotional, proper memoir.
Yeah. So, a lot of the stuff in that book, I don't know how far you want me to go into it, but my dad had quite a, horrific childhood that we only found out about as adults. So he hadn't really told us about any of that, and, just learned of it in recent years. So yeah, it was a really kind of harrowing tale of his early years. And then later on, he was in the Garda Síochána, which is the police force in Ireland, and he was in the police force for many years and had a lot of great stories to tell from that as well. So it was kind of a mixture of, revealing some of his traumatic childhood and, telling his tales of his career in the Guards, which is, just an interesting read all around for me, obviously, because it's, I'm hearing reading a lot of those stories for the first time. But yeah, it was great.
Yeah, it was lovely to meet you on the flight, and here we are.
That's how a conversation can get you places, isn't it? Proper conversation.
And a warning to anyone if you're on a plane or train and see Jamie approaching.
Interestingly, Anne-Marie then lost me during the as we were getting off the plane. She did a great job of trying to. We'd already exchanged details by then, so. We tracked her down. Look, Anne-Marie, your bio goes on to say that you're passionate about eye care, particularly about getting back to basics with a simple act of administration. Tell us more about that then.
Yeah, so like I said, ophthalmology was sort of an accidental, arbitrary, specialty, as is sometimes in our careers. We're just sort of given a specialty to look after. So when I joined the surgical team a few years ago, the ophthalmology pharmacist was retiring, and he sort of took me over one day. I had a chat with him. He gave me his little model of the eyeball, told me to join the UK Ophthalmology Pharmacy Group, and bid me farewell. So without a single day of training or any kind of knowledge about eyes, I then had to look after the whole of the eye hospital. So that was, a baptism of fire. But, luckily the team there are absolutely fantastic and have been, so welcoming and so patient with me while I've caught up and learned as much as I can. And I'm still learning every day. Getting back to basics, it's really about, can patients use the medicines that we're giving them? And so there was a great bit of work done in Moorfields called the Know Your Drops campaign. And what that is getting back to basics around eye drop administration. And within something, I've sort of taken that and that idea and kind of run with it in my own hospital, and have been really well supported by my consultant teams, and just kind of trying to establish that practice in my hospital of kind of saying, okay, within the glaucoma team is where I've started. So glaucoma obviously being the mainstay of treatment, being eye drops. Can the patients use the eye drops? Can they take them? I've literally started this only a couple of months ago, where it's kind of an enhancement to the glaucoma team, where they will refer me patients who they believe have problems with, using their medicines, or perhaps they have never used drops before. So I'll see new patients, and it's just a case of sitting down with them, explaining how to use their drops. And it's been a little bit shocking, actually, how patients who have been on drops for quite a long time, but have, mentioned that they might be struggling, or have now, maybe they've got some new issues where they've got arthritis, and, maybe they can't squeeze the bottles, or they're, it's getting harder for them. So I'm quite amazed at the problems people are having, and the simple act of putting an eye drop in, just the coordination of it, being able to squeeze the bottle. Patients might have, sight loss already, so even seeing what they're doing. And, a couple of tips and tweaks from me, or the use of a device. and they can get it. And, you know, it just means they're getting their treatment properly.
Should we be surprised, really, though?
No, I mean, not really. I mean, we always know we try and give patients as much advice as possible, don't we, with their medicines, but we don't know what they do when they get home. And, you know, I see some patients and it's quite shocking. You know, one poor man was using his eye drop bottle like a roll-on underneath the lid of his eye, but not actually squeezing the drop in at all. Yeah, you can give information, but I think having someone to go through it with you physically, and actually we sit and we have a go and I watch them do it, and it just makes such a difference.
I'm not aiming this at you, I'm aiming it at all of us, in that, you know, we say, wow, people aren't very good at using their inhalers, are they? Well, people aren't very good at using their nasal sprays, are they? They're not very good at using their eye drops. What did you expect? I mean, they're quite difficult to use, aren't they? As you say, you need the dexterity for starters. And these people, guess what? They've got poor eyesight. So they miss quite a lot, don't they?
Exactly. And even I did a little teaching session we have an education session, a weekly education session, which is fantastic in our hospital. And I did a little session on that. And there was a lot of pharmacists who put their hands up and said, you know, I've been doing it wrong, or I've been, you know, I had to give some to my child and I've been doing it wrong. You know, it's one of those basic things I think it's assumed a lot that people can just do. But actually, when you sit them down and they go to do it, it's going on their cheek, it's going, you know, on their eyebrow, and it takes a few goes. If they're squeezing half the bottle into their eye, so there's a lot of waste. So there's all these little things, and it's just a simple thing. But I think it's one of those simple things that can make a big difference. So I've just started at the moment. It's quite ad hoc, and I'm hoping to build on it. But it's, as I say, credit to the Moorfields team I've basically taken their idea, and I'm just doing it myself as well. But I'm finding it extremely rewarding to work with the patients like that and see the progress they can make within a few minutes.
So along those lines, Anne-Marie, what type of things do you see when it goes wrong? I remember over the years seeing case reports of, well, super glue being mistaken for eye drops and those type of scenarios. Do they still happen?
I'm sure they do. Thankfully, I haven't heard too many horror stories yet. But just like I say, from what I've seen so far in the last few weeks, having just started this, you know, people are really struggling putting in their drops, and they're waving them around in front of their face and kind of almost hoping that they'll get one in if they just squeeze it, you know, at the right time. And it's more complicated than people think, I think. And with the added complications, a lot of the population that we're dealing with, especially with glaucoma, are elderly. They've got maybe a bit of arthritis, or like you said, they can't see very well as it is. And it's just, it's the coordination. And so they do a bit of assessment, and we've got some eye drop aids we can use, which also help. And I don't think people are aware that there's eye drop aids out there that you can use to make it easier.
Is there anything then in the research or in your own experience that shows how many people who end up with severe consequences is actually not as a result of their treatment not working, it's as a result of not using their eye drops properly?
Yeah, but I think it kind of comes under the, you know, what we all know about compliance in general, doesn't it? About, you know, patients taking their medication in general. There is, you know, data about patients with eye drops in particular that for glaucoma, you know, about 50% of people are not using their drops properly or at all. So when you consider with glaucoma the consequences of not having your treatment, and you know, any sight that you lose from glaucoma is irreversible. So the consequences of that are devastating, not to use the treatment. And I think there's, you know, other things, reinforcement of the fact that, you know, some patients might think they get one dropper bottle and they finish that and that's the course complete, and they don't realize it's a lifelong thing. So there's lots of different factors, but I think for eye drops, we know that it's about 50%, which is very worryingly high.
I've seen many letters where it's obvious that the ophthalmologist either hasn't asked or not understood, and the patient certainly hasn't revealed that they haven't been using it. And all they see is this high pressure in their eye. So a bit like somebody adding in another antihypertensive medication. But actually, you know, for those of us that work in primary care or look at the record to see that that hasn't been issued or dispensed for, you know, more than a year, you could prevent yourself from that. Do you see what I mean? So again, I know I go on about this a lot, but it does require specialists to have a more generalist outlook on things.
Yeah, and I think as well, it's again, it's patient education. It's involving them as much as possible, and making sure they are fully informed. And it's something that I, in my pattern now with patients when I'm going through the eye drop administration, I'll reinforce those messages that my consultant or the optometrist have said about, this is lifelong, this is treatment you must keep using. Because, with glaucoma, it's tricky because patients often, it's picked up maybe in a routine screening at their optometrist and they're referred in. They might not have any symptoms, they might not feel it. So it's always more difficult for patients to buy into something when they're not actively treating symptoms they can feel. So just trying to get that message across of, this is so important. And if you lose sight from this, you won't get it back. And you've got to keep going with the treatment.
So obviously glaucoma would be a very common thing that people would come to the eye units for. But what about if we flip it around and ask you about some of the really serious stuff and the very interesting stuff, sight threatening, in a very short period of time, or something a lot more scary? What would you tell us about that?
Well, every ophthalmologist's greatest fear is endophthalmitis, which is, an sight-threatening infection and is, considered an emergency. And that's something that can just happen, an infection, that you could pick up from, if you're digging the garden and something flew in your eye or etc. But it can be from obviously every procedure we carry out, surgical procedure on the eye or any injection that we do into the eye, that comes with that risk. So it's always something we keep data on, of numbers of cases, etc. And that's obviously very, very serious and sight-threatening. One of the other things I'm involved with is kind of a specialism within my specialism is I'm uveitis.
You only do left eyes. You don't do right eyes. You only do left eyes. That kind of super specialism.
Exactly. Yeah.
You have no place on this podcast, Anne-Marie, if you're a super specialist. Okay.
I know. I thought Steve would take umbrage with that, my super specialism, but it's with the uveitis team, which is about inflammation of the eye. So uveitis is an umbrella term. So it's lots of different types of inflammation in the eye, but it is can be autoimmune. So this is the non-infectious uveitis. So it's inflammation caused not by infection. It is sight-threatening, and some patients end up on immunosuppression. So I help to look after those patients with the kind of prescribing and monitoring, and bringing my pharmacy hat to kind of help with the monitoring and a lot of counselling with patients, again, giving us a lot of information about these drugs, immunosuppression. So they need a lot of kind of counselling. And I've set up a patient helpline when I first started the job, so that patients, after they have all this information given to them, you can see them glaze over a little, in that appointment, because there's a lot of information. So I always give them the card with the email to say, when you go home and when you have questions, then you can email me, and, we can work through those. So I think a lot of patients have found that useful to be able to contact with just what they call silly questions, but there never is, if you're reassuring them and they feel better, that's never a silly question.
Contact lens wearers are a particular risk as well, aren't they, of corneal infections? That they can be very nasty, can't they, and can be sight-threatening and can happen very quickly. And I can remember a case of in relation to a hospital where, and it was really unfortunate because actually everybody, was doing the right thing, and everyone's saying, oh, that's really important, you need to get these eye drops. But the person couldn't get hold of the eye drops because nobody had them, because they were super specialist type of eye drops. The person didn't really, perhaps wasn't told, or perhaps didn't take in the information. And therefore, then within 48 hours, their sight was severely lost because they didn't get access to those antibiotics quickly enough. When I first qualified, I worked in Windsor. We had an eye unit. And I think that it's like anything, isn't it? If you've never been exposed to it, you're not quite sure. But I've always been super careful about it because I worked on call. And, you'd be told, if you get a call from the eye hospital, it won't happen very often, but if it does, you literally got to drop everything and deal with it, because you're talking about a sight-threatening situation. And so I learned that early on, I suppose, from working on an on-call that included an acute eye unit.
Yeah, well, that's it. When you're dealing with one of the senses, and it's a huge impact on patients if they do end up with sight loss. But stock problems are not unusual. And, when I started in ophthalmology, it's something, unfortunately, I had to deal with all of the time. I think now it's filtering through to the main drug supplies, but for me, it's always been a problem that things go in and out of stock with eye drops and can be quite sudden. So it causes huge problems, and we're often scrambling around trying to find alternatives or
Brexit.
Yeah, but I think that it hasn't helped. Yeah.
There was a piece in The Guardian, wasn't there, Paul? You sent it on our WhatsApp.
Yeah. But no, that was Mike Hewitson when he talked about drug shortages. Yeah.
Yeah. But I mean, eye drops would be one of them.
Be on them.
So as soon as we're not talking politics tonight.
No, it's interesting because obviously, we're always trained to look out for red flags, aren't we? And pain in the eye is one of those questions we've probably asked a million times, but you very rarely get a yes. In fact, I'm trying to think if I've ever had a proper yes, but I guess you're at the other end of that call then, aren't you, Anne-Marie? If pharmacist or a GP or whoever has the yes, they're sent to you. Is that what happens? Well, not you, but sent
to the unit. Your unit.
Yeah. So the unit, the Sussex Eye Hospital that I look after is like a mini hospital in itself. So it has an A&E department. It's got an outpatients, an inpatient ward that's very busy with. It's got 2 theatres. That very busy with, day case surgeries and emergency surgeries. So yeah, I think everyone has quite a low threshold for referring eye things because they just don't have the specialty knowledge. And anything that looks a bit more than conjunctivitis, you would just refer.
Yeah. Jamie, do you remember Dr. Ivor Harrison teaching us? Probably you as well, Gimmo. You're only 2 years behind us.
I remember Dr.
And
Harrison,
he talked about what you just said, and he said, iritis, if you get that pain in your eye, there's iritis, as in inflammation of the iris, and you need to go straight to hospital. And like you, I've asked loads of people. I don't think I've ever come across anyone that said yes, but I remember it.
Yeah, well, funny enough, today I had a colleague who came to me a couple of weeks ago and said, "Oh, I've just suddenly got this big floater in my eye," and I said, "Oh, have you had it before? You have floaters?" And we had a chat about it, and I kind of said, "I think you probably need to go and have you got pain and everything?" And he didn't have any pain, but he just noted this floater. And I said, "I think maybe you should go and get it checked out. At least go to the optician, sooner rather than later, or you pop across to A&E if because while you're at work, kind of thing." And he came to me today and he said, "I had the beginnings of torn retina."
There you go. What about the difficult stuff like the choice about using drugs in the eye that necessarily don't have a license? Are we going to talk about that?
Oh yeah, so using things off-label is not new in medicine, is it? Anything you prescribe to a child is probably mostly 99% off-label or is not licensed. So you're referring probably to the anti-VEGF therapy. So
yes, better explain it to the non-health person as well.
Give us a summary of that.
So basically, there's a few eye conditions, probably the most prominent being age-related macular degeneration. Very common condition as you get older, but still some younger people suffer from it as well. And it's basically extra blood vessels in the eye that are usually very leaky. And we have amazing drugs that have come along in the last couple of decades to treat this condition. And it's one of the top reasons that people will go blind in this country is from this age-related macular degeneration. But these anti-VEGF drugs are injected into the eye, and they help to kind of dry up this fluid and manage the condition fantastically. And they've been a real miracle, in the ophthalmology world in the last, couple of decades, for kind of sight saving. And so there's been a couple on the market for the last, kind of dominated the market since the beginning of this type of therapy. And then just a long story short, there was a few trusts up north who wanted to use a drug that has been used for these conditions for many years, and there's a lot of experience with it, but the company never applied for a license for it. So it's been used in an off-label way. And these trusts wanted to use this as their first-line therapy because it was a lot cheaper than the marketed drugs. Long story short, there ended up being a court case. The drug companies took them to court to say, no, you can't use this drug because it hasn't got a license for this indication. And it went to the High Court, and in the end, the High Court ruled in favour of the trusts, that they should have permission to use this drug. So when that ruling came out, it sort of made everybody sit up and say, oh, because using this drug it's just as good as the other drugs. The evidence says, and we know it is, using this drug potentially could save millions and millions across.
So it was massive amount of money, wasn't it?
Yeah.
Millions.
Yeah. Millions. So we decided to adopt that policy. So we offer that to patients. We would, use it as our first line drug, but we offer it to patients as one of our choices. And when we brought it in initially, I was actually quite involved in having those conversations with patients about the drug. And it's amazing, when you give the patients the information and you give them the choice, they were overwhelmingly happy to make that choice to save that money for the NHS.
There you go. Shared decision making right there.
And they were extremely grateful for the NHS. Some of them scolded us for not doing it sooner and saying, why haven't you been doing this before? And, we said, well, we weren't allowed to before. And so it was really amazing. Yeah, when you explained it to them, they just said, well, yeah, of course.
So that was the piece, wasn't it? And I've got it up in front of me. Don't think that I know this off the top of my head, because I don't. But Lord Justice Underhill said, there is nothing inherently illegitimate in prescribing decisions being influenced by cost consideration where the evidence base shows that there's no difference in efficacy or safety. And this was the point, wasn't it? Is that we are talking about a medication that did have efficacy in this condition and was safe. And therefore, that's why I assume they ruled and said that this was acceptable. But as you said, it is about choice. So you do give a patient, they do get a choice, don't they, as to whether they can or whether they can't. So it's great to hear that, a lot of them, whatever the majority was, that said, yeah, I'll take that, because actually for the greater good. And, I guess pharma will have a different view. Of course they will. Yeah. But yeah, it's a good story. And it was very much an eye specialist area, wasn't it?
Yeah, well, it's health economics in practice, and it's the patients.
The empty chairs, Rachel Elliott's empty chairs.
Yeah, I really felt like some of the patients were saying, this is great. This is me doing my bit to contribute to the NHS. And it was really, it was really fascinating. And as I say, there was overwhelming positive response to it. But yeah, the burden of the cost of these drugs, and it's, when you start the medicine with these patients, it's a longer term thing for most patients. Some patients, about 10% of patients, won't respond to this treatment at all, no matter what option you give them. The fact that we have confidence to present this treatment with the evidence to say there's no difference, we're confident in that. It's just the price difference. It was a no-brainer.
I can remember for the early days of switching to generics, it was a similar story, wasn't it? Was that what patients didn't like was when it was done without telling them, and they thought they were being fobbed off with a cheap alternative. But actually, if you sat down and gave them a choice of a salbutamol versus a Ventolin and explain why, most were happy to give it a go. And again, like you say, I can remember that, hearing people saying they were happy to help if it meant that money went back into their GP practice or whatever.
Well, remember that the piece that we had in the last episode, that was the humour from the Now team about the generic.
Well, didn't that get cut out?
I don't think it did it?
Oh no, we ran with it in the end, didn't we? Anne-Marie, we'll get pulled up for using the terminology up north. So just for completeness, it was NHS Darlington CCG versus Bayer in the original.
It was, yes, up north. But I like up north, so I do it.
And how mean would it be if I got Anne-Marie to actually say correctly the three MABs that were involved in the case?
Very mean.
Just for bonus content. I won't. But anyway, the product we were talking about was called Avastin. That's the trade name. And it's one of these monoclonal antibodies. And there were 3 of them, but we won't go into the names unless Anne-Marie wants to roll them off the top of her tongue.
Well, aflibercept and ranibizumab. But
there you go.
Hey, there we go.
You rule.
The Oral Apothecary is sponsored by Jamie Hayes Executive Coaching and OneLessPill.com.
Okay, well, that's great stuff. So we will come back in the micro discussion to talking about eye care again, but fascinating to have specialists on. I know I give sometimes specialists a hard time, but as I always say, we absolutely need specialists. So 3 things. I'm sure you know the score. The first one is, what would you like to give us as your desert island drug?
Okay, so this one, I had to really debate about, because the first thing that came to my mind, I didn't think you'd like, and I could already hear the groans of derision.
What?
And I was, they're not going to like it. And then I
Usually
thought,
Jamie that doesn't like them.
I thought,
it's not a popularity contest, Anne-Marie.
I thought then I should really pick something eye related, to fly the ophthalmology flag. But then I went back to my original one because I just have way more stories about it. And I'm a big believer in you should go with your gut instinct. So
Agreed.
I'm going to go with it. I'm going to say it now and wait for the eye rolls. It's warfarin.
Hey.
Love it.
We love warfarin.
Yeah, I worked in the anticoagulant clinic.
Yeah,
I
gave
cut
us an
my teeth in
industry.
the
Gave us
anticoagulant clinic.
Wisconsin agricultural, whatever it was. Alumni. We talked about that in final ingredient.
Go on then, give us your story then. We all love warfarin. So your thoughts were misplaced.
I have multiple stories, so you can, as I said, feel free to edit this because it might be a ramble. But my first sort of memory of warfarin, I have a long history in pharmacy. I started working in my local chemist shop when I was 16, and I was the Saturday girl. I would put away orders and serve customers and, clean the shop and etc.
Like Claire Howard, by the sounds of it.
Yeah. So the pharmacist there was, the team there was so lovely. They were like my second family. And he encouraged me to come into the dispensary and start looking at prescriptions. And I was very curious and, about the drugs. And I'd ask lots of questions. And he started getting me to read the scripts and getting the things off the shelf. So starting to do a little bit of dispensing. So one of the first prescriptions that I picked up, I could read, that says warfarin. And it's 1 milligram and 3 milligram. And back in the day, it was big pots of tablets that you had to pour through this counting
500,
machine.
I think there were.
Yeah. Which I found using the counting machine quite thrilling for quite a long time. So I was excited to do that. And I dispensed the blue and brown tablets and I left them on the counter for the pharmacist to check. And he looked at me with this kind of sideways glance. And he then very patiently explained to me how you really shouldn't put 2 strengths of tablets into the same pot. So I thought, they're different colors. I can save. I think I was economical before my time. I thought I put them in the same pot. That'll save money. Only one brown amber pot. So that was my first dispensing error officially was warfarin.
That's a warfarin pick and mix you've just come up with it. Yeah.
Exactly.
No pink ones.
And then, as going on to do pharmacy and training in your pre-reg year. And, as a newly qualified pharmacist, it just always gives you the fear. So you see warfarin on a drug chart and you immediately red flag in your brain and you check everything meticulously and you're checking INRs, blood tests, and it's one of those ones that gives you the fear, what I would call the fear. And then, later, as you get a bit more experience, it's a great, teachable drug when you're trying to teach your trainees. There's so much to talk about with it. It's interactions, it's monitoring, it's all sorts. So it's a really good teachable moment drug. And then also I did my time in the cardiology wards, which I thoroughly enjoyed. But I saw kind of my first examples of what I'd call blind prescribing, where you have, you come in, you look
unintended.
Yeah, you're getting ready for your future career.
But yes, excuse the ophthalmology pun. But so you look at your hand over, it says this patient's got atrial fibrillation, they've started them on warfarin, which you think that makes sense. That's the guidance, that's what should happen. And I'd say to myself, okay, I need to go and talk to this patient and counsel them on warfarin. And we know there's a lot to say about warfarin. It takes a long time to give all that information to patients. And I chat to the patient, and within about 20 seconds, I realized there's no way this patient's going to be able to take warfarin. They're slightly confused. They won't be able to change their doses. They might not even be able to attend the warfarin clinic. So I speak to the doctors and say, you cannot prescribe that for that patient. There's no way they'll take it. So it was a real kind of example of prescribing on paper and not for the patient. And, you come across that a lot, but that example just always stuck out in my mind of that kind of blind prescribing. And then finally, both my dad and my sister have both had blood clots and ended up on warfarin. So I'm quite grateful for warfarin because it's helped them. And so that is why I did choose warfarin.
I think it's a brilliant choice. I think your instincts were wrong in that warfarin is, as you said, it's got everything. It's got interesting chemistry. It's got an interesting history. It's got one of those mode of actions that you can put on a chart, so on a picture. So it's quite nice to watch. And then it's got lots of interesting side effects and interactions, interacts with weird things as well that we like to, it's one of those drugs that makes pharmacists sound interesting, I think. So
you're describing pharma porn there.
I think you are. I think it is one of the best drugs for pharmacists to talk about. So
well, it was picked by Dr. Mark Holland as well. but that is for different reasons. So we love a bit of warfarin. We don't see it very often.
Never turn your back on a warfarin script.
Yeah, I'm liking that. I've not heard the fear. It sounds like the crack.
Here's a question then. What other drug came into mind when you mentioned the fear?
Amiodarone.
Okay, that's one. That wasn't the one that came into my mind.
Methotrexate, yeah.
Yeah.
Fluorpromazine.
Oh, no, okay.
All the dirty drugs. Should we go for it? Top 10 dirty drugs? So as you're talking about pharma porn? No, let's move on. Right. Okay. Excellent, Anne-Marie. We'll definitely take warfarin into the oral apothecary formulary. Okay. Next up then, what about a career or life anthem for the oral apothecary Spotify playlist?
So this one I found super easy. I knew straight away what I was going to pick. And I'm not really a musical, buff, and I love music, but I always never remember who sings what or what the song is. I just like what I like. But the first song that came into my mind was Build Me Up Buttercup by the Foundations. And that is because from back in uni with some of the girls I lived with, that song would come on. We would all go to the dance floor. But also it was a song with one of my particular friends who, if I heard the song, if I was out and she wasn't out, you would call her no matter what time of the morning it was and sing very loudly down the phone. So, and then I found out later on, in many years later, when I met my husband, this song was his song, that he would do that with one of his friends too. No. So that was a funny coincidence. So Build Me Up Buttercup is got us through a lot of labs and singing that for many years, because I did 2 degrees. I did a degree in Ireland first with this particular friend, and we both came over to the UK and did pharmacy. And Build Me Up Buttercup got us through long days in the lab.
Okay, so there we go. We had the fear, now we've got the crack. Excellent.
There's a slight pharmacy link. Buttercup's in cough mixture, isn't it?
Yeah.
What was your first degree, Anne-Marie?
It was just kind of a general science degree, so chemistry in the end. But yeah, I kind of did that, and then I took the meandering route to being a pharmacist. So I spent a lot of time in uni, so I did that, and then that was 4 years, and then I came straight over after doing my finals and I did my undergrad here in Brighton, and did my pharmacy straight away. So I took a meandering road, but no regrets.
Excellent. And the third and final thing is a book for the Oral Apothecary Library.
Is the book. So I'm not a massive nonfiction reader. I like to read actually autobiographies a bit as well. But actually, you mentioned this book, actually, Steve, in an earlier episode that I listened to, and then I had wondered if anyone had made it their book. But anyway, it's going to be my book. So this is Gonna Hurt by Adam Kay.
Yeah.
I chose it because I absolutely love comedy and stand-up comedy, and this book is absolutely hilarious. Laugh out loud, spit out, really funny. But also it's really raw and real and devastating, and kind of takes you on a real emotional roller coaster and the reality of what it is kind of working in the NHS. And it kind of echoes that dark humor I think some of us develop when working in the front lines.
Absolutely.
And I think really importantly, it gives us a really amazing insight into the life of a junior doctor. And I think the general public, everyone should read this book. They would just they'd be so shocked at what, junior doctors have to put up with. And I think they are one of our closest colleagues when we work on the wards, and I really think a lot more than clinical knowledge, it's the relationships that we build with our team on the ward and with our colleagues that makes us better at our job. And this book, or having an understanding. So I think, in previous episodes, I've heard you guys talk about, empathy and empathy for patients, which of course you've got to empathy for patients, but I think we've got to have empathy for each other, and empathy and respect for everyone's role in the MDT. All of my colleagues, my doctors, nurses, Occy Health, physios, we're all a team. We're all trying to do our best for the patient. And the more empathy we have for each other, I think makes us work so much better together. But yeah, I think this book just drives that home. It's just you laugh and you cry and you feel. I think it's kind of shocking, but it's an amazing read, and I would recommend it to anyone.
It might have been why we were talking about it. There's a TV series, wasn't there, about 2 years ago, and I think that's why we were talking about it. I've not read the book, but I've seen the TV series, and it was very good.
I've read the book, and it is everything that Anne-Marie has just said, and you couldn't have said it better. Everyone should read it. And, he's a classic example of somebody who found it just so tough that he got out.
Yeah, and when you read it, you don't blame him. either. It's it's a tough life, but but I just fills me with so much respect for my colleagues, and I try and impart that to when I'm teaching juniors, when they're first coming in, and we've got our agenda, as pharmacists on the ward, and we've got the things that were important to us and we want to do. But, that doctor might have just come out of a room where he's broken really bad news to a patient. And, you don't want to go up and, you've got to pick your moments sometimes to talk about more trivial things, or obviously then when you need to know when things are important. But it's just having that understanding of the different roles and just working together, I think, is really important.
Okay, so This Is Going to Hurt by Dr. Adam Kay makes it into the Oral Apothecary Library. Thank you for that, Anne-Marie.
Very good. And a shout out for all of our junior doctors as well.
Indeed.
Our micro discussion next, looking at an article in the British Journal of General Practice, The Burden of Acute Eye Conditions on Different Healthcare Providers, retrospective population-based study, and from colleagues from Swansea University and Cardiff University in South Wales. And so they analysed data from the SAIL data bank, the Secure Anonymised Information Linkage Data Bank. And they got some information on how people were showing up to general practice and primary care, accident and emergency. And then in Wales, we have the Eye Health Examination Wales Service. And from a pharmacy perspective, we've had the Common Ailment Scheme for some time. And the year that they were looking at takes us back a few years. They were looking at 2017 to 2018. What happens with research? It's only just been published. Through which lens did you look at it, Anne-Marie?
Broadly speaking, I kind of, the data that was presented there is completely unsurprising. Eye services are one of the most oversubscribed services in the whole healthcare system. It wasn't shocking. And actually, it just made me think about they're only really talking about acute services, but actually the same is true of our other, longer term services like glaucoma, like cataract lists, they're backed up massively. So the burden is kind of across all eye care services. But I found it interesting when they looked at the breakdown of the days of the week and the different people who present. And, unsurprisingly, again, Mondays are terribly busy because people don't want to go to the doctor at the weekend, and they rock up on a Monday when they think they
gotta go to work.
Yeah. And then I found it interesting about the proportion of men who go to A&E. And I thought that actually, just from what we see coming in, I guess, a lot of tradespeople get penetrating injuries or those type of injuries. And I think that's, in my mind, that's what sprung to my mind when it was proportionally more men that would go to A&E in that demographic. A take-home message for everyone is wear your safety goggles.
What do you make of it?
Looking at taking a step back from it, you could replace eye with other things with this, couldn't you? A lot of it was about, not inappropriate, I don't want to use that word, but people presenting perhaps to A&E and other services with conditions that could be better self-managed. And then it does go in a bit into the challenges of self-management. So I think what was interesting was the stuff around, I think I read it right, the confidence of people going to pharmacy and things like that with eye conditions, as opposed to, going straight to A&E and perhaps either not being aware or not being confident that those alternatives are out there. You could apply that to other stuff, but this paper talks about it particularly with the eye. And then there's also the stuff in there around how are we best managing eye infections, because we probably haven't cracked that yet. I know it's 2017 and it might be better, but people presenting, well, not inappropriately, but people presenting to A&E with eye infections when that's something that could quite easily be treated in a number of places. What I didn't get a sense from this was, where does optometry fit into this? Because it talks about general practice and pharmacy. I didn't really get much of a sense of it, of how better we could be utilising optometry as well. So I thought it was interesting. My sense was it didn't really tell us anything that we didn't know already in terms of what applies to other drugs and conditions. We know people present to A&E with stuff that could be managed elsewhere.
I think you're dead right about it being a blueprint. And so obviously in the English service, we're talking about primary care networks now, including not just general practice, but optometry, pharmacy, and dentistry. And so I, like you, when I read this, thought this is great, because I don't think we have the service that they're describing in Wales, with optometry service, because out of the 365,000 episodes within that year 12-month period, 46% went to general practice, 52% went to optometry, 1.5% to emergency department, and 0.5% to community pharmacy. And yet what they said was that when you looked at all the things that general practice did, they were nearly all, 76% of the prescriptions were for lubricants, because such chronic eye conditions often present as an acute issue. And so I was left thinking, wow, general practice is talking a lot about, let us deal with the stuff that only general practice is good at, and let others do other stuff. So Pharmacy First being another good example. So I thought to myself, actually, wow, isn't this brilliant? Because I think this paper was trying to say, we already have an optometry service in Wales, but it's already not being used as it should do. We are not educating the public, and we're not educating general practice enough to deflect those people away from general practice into optometry and maybe community pharmacy. So I thought the paper was really neat in what it was trying to say. And also I loved the bit at the end where they said that in future research, if you're going to change a service, you need to examine for unintended consequences of change. And I loved that. But just on the negative, guys, I'm sorry if anybody's listening, but as an associate editor of a paper, it was really difficult and it was pretty poorly presented. I had to work really hard to work out what the numbers were and who was going where.
I do agree with you. I had to read it a few times to understand it. I picked up on there's a few things. I did some research with the SAIL data bank a few years ago with a cardiologist. He was doing his dissertation for his diploma in therapeutics. And so we pulled the data on statins in primary and secondary care. He had a unique combination. He was a cardiologist, specialist registrar, and a coder. So he was able to interrogate the data bank himself without relying on some of the expert support and help you need from SAIL to be able to get some of this data out. So well done to all concerned for pulling this data out. But the bit that I went to was the health literacy stuff that they highlighted again. And then they highlighted, even in what we were talking about earlier, Anne-Marie, that poor health literacy is associated with poor outcomes in a range of eye conditions. So we've talked about health literacy a lot of times on the podcast over the 6 series. And yet again, it's another startling example of, people in less off and socially deprived areas, have less healthcare and have poorer outcomes, even in this specialist area. I sympathize some of this. It's what you said earlier when we were talking about red flags, and because it's the eye, people don't want to miss it, do they? And so I think the system is set. It's a very difficult one to call sometimes, I think, when people are presenting with an eye, aren't they? And I think they err on the side of caution for obvious reasons.
Yeah, I think it's similar to, with pediatrics as well, isn't it? If someone comes with a child, you've got a way lower threshold for referral, and that's just built in.
But I think they go on to say that GP trainees, when asked, say they find it really challenging dealing with eye conditions. So going back to my original point, their point is funnel as much of it as possible into an optometry service. 93% of all the prescriptions written by GP practices for these cases could have been issued by people in optometry. So it's a bit like dentistry, isn't it? I mean, you just pick the right people to do the right jobs. And if you want to go back to my oral apothecary abstraction that I wrote last year about this idea that what is it that you need? And if you need a diagnostician and somebody that can prescribe in an area that they're clinically competent in, why wouldn't you go to an optometrist if it was an acute eye condition?
Yeah, I totally agree, Steve. It's, they are specially trained, and yeah, it's definitely a situation where a specialist is required.
Just a few things on the SAIL database, which is quite interesting. It's been going a little while. I think it celebrated its 10th anniversary 2017, it says on the website. And I think in the paper that we're looking at, it says 85% of practices in Wales. So it's got great coverage and it's increasing all the time. A couple of years ago, they said, look, Swansea University third-year medical school students were given access to the data bank as part of their third-year projects.
And they broke it.
So it's still growing. It's still developing, and I suspect it hasn't had its sort of peak yet, because it's obviously the data that it has and it's getting all the time.
It links up in ways that very few databases do. Yeah. So you made me think, James, I wonder if they've let AI have a look at it, because that could probably make some connections and some links and some trends that I know they're very guarding, aren't they, of it? So they probably won't But it'd be interesting to see.
They've got lots of collaborations going on as well, and so I think you'll see more and more from them over the coming years. Okay, thank you very much. A big thank you to Anne-Marie for joining us on the Oral Apothecary, for sharing her stories, her desert island drug, and her book for the Oral Apothecary Library. Be careful where you sit on the plane next time, Anne-Marie. Coming up next time, we'll be joined by Tommy Whitelaw. Tommy is the National Lead Person-Centred Voices Health and Social Care Alliance in Scotland. Join us next time on the Oral Apothecary. You can contact us via Twitter at Oral Apothecary. I should start calling that X, shouldn't I? At Oral Apothecary. We're on LinkedIn. You can email us at oralapothecarypod@gmail.com. The website is theoralapothecary.com. Gimo now with a final ingredient.
Okay, so thank you, Anne-Marie. That was fantastic. You used the line in the bio you sent us, which I really liked, was that eyes are definitely the window onto our health. And so I think we really enjoyed that. So quick final ingredient for me today, again, taken from Twitter, not X. I don't like the name X. And on a theme we've covered many times, and that's alternative to drugs. In this case, alternative to drugs for the management of mental health. So in this article that was linked to on Twitter, old age psychiatrist Dr. Krish Vedavanam, sorry if I pronounced that wrong, James Warner and Sebastian Zaidman were asked a question about depression in older people. What is the best first-line antidepressant to prescribe for older people? So the answer they gave back was both heartwarming and heartbreaking. And the first-line antidepressant, based on their experience, they recommend was companionship. Studies have shown that social isolation has a detrimental effect on mental health in older people. So once an older person has been diagnosed with depression, they stress that first you need to try and establish any social factors, such as loneliness, that might be involved in the course before you even think about drugs. In fact, the second line of treatment is cognitive behavioral therapy, which we know got a growing evidence for effectiveness. And only then would you be considered an antidepressant. So I wonder how many times that happens in practice. I was talking to a GP today who said there's often resistance, particularly from families, when they recommend non-drug therapies. And I wonder why that is. Loneliness is not an easy thing to tackle. It's a topic close to my own heart. As I've said on it before, my dad died last year. And so my mum is one of the 2 million older people, 2 million in England living alone. Age UK say that more than 1 million people say they go over a month without speaking to a friend, neighbour or family member. And that's just mind-blowing to me. So no wonder there's an epidemic of depression and we're seeing so many antidepressants prescribed. So there we have it. It's not a cheerful one, but I guess this isn't just an issue for healthcare professionals treating depression. It's something for us to all consider. If loneliness is so prevalent, it's an epidemic. So we need to do something about it. We're all getting old after all, and we may find ourselves there sooner, we think, amongst that number.
You have been listening to a 3 Apothecaries production. Sound engineer Jimbo Slough, original music Jamie Brewster, artwork by David Baker and Jacob Howard.
Thanks for listening to the Oral Apothecary podcast. Caution, you may spontaneously combust if you take it too literally.
This episode of the Oral Apothecary is sponsored by onelesspill.com, a medicines optimization consultancy.